lasers, complications about permanent fillers and all that things, and even before being introduced to Endolift. So it is an area that I'm passionate about, following your complications. I'm not just going to list those, but I'll go directly to some of the issues that we had. Initially, this is one of my cases in California that we reported, removing permanent filler such as silicone. In this case, it was silicone. We published that. It required cuts to go to the under mucosa. We sometimes had to remove part of the muscles that are close to the orbicularis. The silicone is in multiple layers, or the permanent filler of another type in multiple layers. Really excising them is a painful, unpleasant job, because there's no clear tissue planes. It depends on the material, but a lot of the time, no clear tissue plane. But it actually does teach you about the injection techniques. You start saying, oh, there's a bolus technique here, there's fanning technique here, there's threading technique here. Depends on where the permanent filler material. This is another case, removing permanent filler from under the eye, silicone injection. Again, those all dramatic. They require excision. People have scars. It's got substantial risks with it, till I got introduced to the Endolift. I'd like to have two branches of dealing with permanent filler complications. Either people they are not in crisis, or people who are in crisis. If you're not in crisis, they don't like the lumpiness, they don't like the shape, or they don't like the idea of having permanent filler in the face, and they want that removed. And there is patients that come in crisis, such as this lady, and they're arrived when there is an acute complication, erythema, and active infection. Generally, when you work with patients who are in acute crisis, you're dealing with a major complication. It could be a life-threatening complication. These patients in the body sometimes can go to the ICU, so you have to intervene. You don't have to weigh risks and benefits of intervention. You have to clean this material, you have to remove it. Generally, my technique has been to insert a cannula after removing that and leave these cannula for about 3 to 5 days, irrigating daily, once or twice, with depends on the culture and sensitivity, with something that has usually an antibiotic solution, gentamicin and other stuff, till we have clear fluid coming up, until the skin completely clear out of the erythema. With Endolift, it really changed my philosophy looking at handling and working with a permanent filler, because at this time, I started feeling that I don't need big incisions. I don't need big cuts. I don't need to cut tissue and remove it and dissect it. I can create channels. I can soften the hardness of the filler, and I can extract it, just like you would extract a fluid out of the body if you have a cyst or something like that. And I'm not going to talk about the science behind it, because Dr. Roberto did a beautiful job. But I'll show you some sort of the cases and what are the two important philosophies with the Endolift that I've seen, doing maybe about 5 or 6 cases of the permanent filler complication. One is that you can create channels to the areas where there's permanent filler. So you can create nice small channels for that permanent filler to be delivered. And second, a lot of the time, the permanent filler is associated with fibrosis and hardening, and the material itself can be quite rigid. With using the fiber into that material, you can make it a little bit more softer and allow it to be more liquidy or jelly type, and allows you to express it out of the areas. And particularly in the areas in the face, there is no luxury of making big incisions with no risks or complications. Okay, so I want to talk about the fiber selection. It really depends on the areas, but in the body, I've generally used the 300 micron fiber, and it worked quite well for me. I want a little bit of more rigid fiber, bigger fiber, to be able to create appropriate channels. So, and this is here, not my cases, but international contribution. This is for things that if you're a dermatologist, you want to do something in the office. You can see here working with a fiber that's thinner than me. Probably this is about maybe 200 micron fiber. It looks like quite a thin fiber. But you can create small channels to express the material, and either that is inflamed or is sometimes infected. I have not performed that in the clinic. Usually I perform it in sterile operating room environment. I treat people with antibiotic preoperatively, and I prep them like they're going for a big implantation surgery just for the risk of infection, particularly if a person coming that do not have an infection. The last thing you want is to leave them with an infection. But you can express this material, but what I suggest, if you decide to do that in your office for some areas, then make sure that it's prepped sterilely, like you're doing an implant, and probably start them on antibiotic maybe 24 hours or 48 hours, depending on your preference, just so you don't deliver an infection in that. And you can see here that if you're creating these small channels, you're trying to express that material as a liquid, and you're quite successful in removing some of this. I will zip into a couple of cases. These are some of the cases of the lips that traditionally I would have cut these lips to try to remove the silicone there, but with the Endolift you can create small channels and express it and get it quite more naturally looking lips. Sometimes the goal is not to remove every dot of the permanent filler, but to remove enough that the tissue starts acting normally and looking normally. This is another case where we have expressed small pockets that was causing irregularity in dimpling. This is done in the clinic, not in the operating room. This is a patient who has previous extraction of permanent filler, and then we use the Endolift just to extract some areas that was causing undesirable shadows or a dump or lumpiness that the patient want to address. Now let's show you a couple of more interesting cases. This is a young lady. She works quite extensively in the media and whatnot, and then she has a permanent filler problem. And as you can see, these people, when they smile, they have unnaturality. They can't really smile. She's trying to smile, but she can't because there's extensive fibrosis in the cheek. It looks quite heavy at the nasolabial fold, although you don't have nasolabial fold, but it looks unnatural, looks really stiff and rigid. And it does not give you instantly feel there's something wrong about this face. This is her MRI. I usually do on those cases MRI with contrast to look at the filler material, the inflation around the material, and I usually almost do a roadmap on these permanent fillers. So you'll see here there's tons of permanent filler in different pockets in the face, and as you come more superficial to the cheeks, you're going to see extensive amount of filler in the cheeks. You can see all that permanent filler, some of it radial, some of it fanning incisions, fanning technique, and some of them are in lumps as a bolus technique. So in those cases, usually I mark all the areas, looking at the MRI and palpating the areas, trying to find where are the big pockets that are creating problems, and making this cheek fat pad very stiff and unnatural. And then we prep in the operating room, and then we try to express everyone. I usually use about 3 incisions, one here, one just under the sideburn hairline, and one under the earlobe. And you can see here you're able to remove small amount from each pocket of a material that looks like more like a paste. In the past, without the Endolift, I would not have been able to do that, or it would have been very difficult, or I have to be making at least a mini facelift incision to arrive to these pockets to try to release it. And then you can see here immediately after we worked with one side is much smaller in size after removing all these pockets, while this side is much more fuller. That's with TUMI immediately after surgery in the operating room. So you can feel how much of the inflammation and the permanent filler material that you can remove, and how this much look like a more nicer, natural silhouette compared to the other side. And again, these are, hopefully this video shows, it's kind of good video because it shows you some of the fibrous attachment that we come to. It's not easy glide like what we've seen with your usual Endolift patient. You're gonna encounter some hard areas, really stiff areas as you go through. I wanted to see that to play, it's unfortunately didn't play. And this is immediately after the procedure. I usually do those as a local anesthetic or with a little bit of sedation. There's a bit of more swelling, but we targeted most of the dots that we want to remove. This is her after 1 month of surgery. Now she has a nasolabial fold, before she didn't have. And then if you can see here, hopefully this video will play for us, as she smiles, she has a lot more lift on her cheeks. She's starting having some naturality movement. A lot of the permanent filler stuff is a more dynamic problem. You feel when they express and use their face, they don't look natural. That is after 1 month. Doing much of significant incision without significant downtime, without significant cuts. And she was quite pleased with the results. So this is a case where it has been previously removed. This is a patient who has a permanent filler problem, had 2-3 trials of removal. Some of it was residual. She still have, again, that's I think one of the stigmata, no nasolabial fold because they've been injected full, but it still looks unnatural. It doesn't look pleasant. Again, I do the marking. I see where are the areas that need to be treated and removed. And this is in the operating room. Even if I'm doing it as a non-general anesthetic procedure, I still prefer the operating room for sterility. In this area, most of the work was towards the nasolabial fold. That was the area with the residual permanent filler. And again, you can see here more of a dramatic difference. You can see how much is the treated side compared to the left side. You can tell I'm a right-handed surgeon. I start always on the left side of the patient. And this is immediately after surgery. And I think when you're treating permanent filler problems, I think usually what I try to do, try to weigh the risks and the benefits of treatment. If a patient have very little problems and the permanent filler are not creating major issues for them, they're not creating unnaturality, they don't attract attention, they're just there, I generally advise my patient to just leave them alone. They're not causing you problems, they're there, just leave them alone. Because if I intervene, I can give you a problem, such as an infection or cellulitis or irregularity that you need to go on to fix. So if they're not causing you a problem, just leave them alone. If they're causing you a problem, then we try to balance how big is the problem and how important fixing this problem to you compared to the risks that we can carry through this procedure. There's two major risks that I find. One, and probably foremost, is an infection. And I've seen it, it happened to me. Sometimes you need to treat those patients with antibiotic and irrigation for a month to get it cleared. The second is creating irregularity. And it's extremely common when you're going to remove patients' volume that was there, you're going to create some dimpling. I find after Endolift, there's a lot less dimpling because it's creating some sort of tightening effect. So I see a lot less dimpling that I need to correct with fat transfer. Usually permanent filler patients do not want any type of filler. Even hyaluronic acid, they don't want it, and it's not advisable. So if there's dimpling, you probably want to use either a fat matrix or you want to use their own fat to fill any irregularity problems as a second procedure. Occasionally, as one of the cases, I can do a mid-facelift if that is needed at the same time. Rarely that we can have either a nerve injury or other major complications if you're too aggressive. I've seen it only with one of my colleagues treating a very hard, stiff material, and we're trying to express it, and it did create a buccal branch injury. So remote risk unless you're dealing with incorrect planes, but it can happen, and you need to inform your patient about it. In conclusion, I try to establish this idea, and I think out of permanent filler problem, this is the most important to me. I don't think there is anything attractive of being permanent in your face. What looks good now is not going to look good in 5 years, or it's not going to look good in 10 years. If I give you the perfect lip now for a 20 or 25-year-old person, it's not going to be their good lip when they're 45. So I really do not think doing anything permanent in the face as remodels change over time, it's not going to look good in the future. I've seen that with permanent filler. We've seen that with some sort of permanent implantation in the face, particularly cheek implants, where they don't look natural or they don't look right to the face after 10, 15 years. So I commonly try to advise patients, I really like things that you can mold and change over time and accommodate the changes that will happen to your face. I do not think permanency is something attractive or desirable. I don't think permanency is safe because it can create risk of infections. I don't think permanency is safe because it creates risk of lumpiness, and I do not think permanency is never safe in the face. So generally, I really stay away from permanent fillers, even the one that has some sort of PDF approvals or FDA approvals. Thank you very much, and I hope I kind of like tried to rush through this presentation. If if you have any questions, or I think, go ahead. Dr. Matt is very energetic. You're always asking good questions. If you don't have a mic, it's okay. We're a small crowd.
Thank you very much. My question is, we have currently in the clinic with Dr. Silas a patient that came for a retraction after threads. We did MRI, and there was underneath permanent filler. So actually, she has now a lot of retraction. My question for you, when you have all these irregularities, dimples, static, dynamic, do you think Endolift can also work as you shown, as a subcision effect? And what about the meeting between Endolift and threads? Is going to cut the threads? Is going to make a side effect? I don't know what's happening. In this case, maybe you can mention it's Aptos thread, so it's PCL, PLA thread. Do you think it could be a good idea or a bad idea to use Endolift in this specific case where we have in the superficial fat some threads and just underneath a big mass, a big bomb of permanent filler since 6 years? What do you think?
Interesting. Wow, you're presenting complicated thing. I will give you what's my general thoughts, and then maybe I will ask Dr. Roberto for more thoughts about the energy itself. I think threads, after some while, they're not carrying any substantial effect. They're just there. After 2 years, these threads are not really providing substantial lifting. So either you cut them or you go through them. It's really not going to make a big difference to the patient in terms of effects. I don't view the presence of threads as a contraindication to doing Endolift. I perform surgery sometimes, not even Endolift, on patients who already have threads and didn't work for them. You just have to be prepared to deal with more difficult planes, in my mind. I think you can target the long-standing permanent filler for removal. It's probably going to be a more tougher job because of the threads will create some fibrosis and adhesions, and you can't get to those. I do think that is possibly the threads PDS or PDSO, is that going to be taking up the energy? Can we cut it through that? What do you think, Dr. Roberto?
If there are some threads, for sure, especially, I combine usually Aptos with Endolift, but I perform first Endolift and maybe in the sensation also the Aptos threads, for example, the Nano XL Visage for here or the Nano Visage for here. So I combine in different plane and different level the two technique at the same time. Endolift above, yeah. I mean, Endolift has to be very superficial as at first. Then you can work in the middle a little bit deeper with the Aptos threads for sure, or Silhouette Soft. I mean, so it depends which one you want to use, but I use Aptos like you. And honestly, when there are some threads, I wait at least 6 months before to perform any Endolift procedure, because I believe that the subcision can create also for Endolift. For example, I use Endolift for acne scars, the deeper acne scars. Yes, to release and then inject hyaluronic, so it works like this, as works for the cellulite holes. So there is the release of scars, of cellulite holes, and I think that you cannot perform any heating or subcision technique where you use threads. Even if you try to stay in a different level, you cannot be sure for sure that you are in a different level. So safely, I wait 6 months after, if the patient has the procedure after some threads, or in the same session immediately after the Endolift, I perform threads. Which one?
I just asked Basil. She had a thread 1 month ago. She complained of big retraction, big dimples, not because of the thread, because of the permanent filler plus the thread, etc. So now she's complaining. Shall we do a normal subcision release, let's say, with our surgical instrument, or can we use Endolift? Or you? Yes.
I think it sounds like her problem is mostly from the permanent filler, because the threads themselves, they don't really cause problems. It's normal threads that people use and been there for 3, 4, like 6 months. So usually, even if the creating dimplants is softened, the thread is being remodeled and absorbed. So I think most of her contraction problems are from fibrosis secondary to the permanent filler. If you address the permanent filler, I think the dimpling will improve. I find the threads is just complicating the equation for no good reason. If you want to wait a little bit more time, they absorb a bit more. It's up to you if there's no urgency. Is that fair?
Correct.
But I think the good question that Dr. Mack, can we cut threads with an Endolift fiber? Yes?
Yes.
Okay, that's very helpful. So at least if you have threads done to your patient recently, don't do Endolift in the same area because you can cut through threads. That was a very helpful information.
Yeah, again, when sometimes we use also the biostimulating threads, for example, that sometimes create a curve, you can use even Endolift there to
release
a
it.
little bit, yes. Or you can enter and remove it for sure, but you can try earlier with fiber for sure.
Excellent. Okay, thank you.
Any other question? Okay, thank you, Dr. Basil. Third, let's introduce Dr. Firas Hamdan. He is a professor of plastic surgery from Lebanon. Please come to the podium. Thank you, doctor.
Hello? Yes, okay. So we're back on. Thank you, Ms. Marina, for having us here. Beautiful gathering tonight with excellent products. 3 different companies so far, the Endolift, and I think before that, Renuvion J Plasma was on. And now we would like to follow 2 excellent speakers, Dr. Basil and before that, Dr. Roberto, to now introduce a new kind of filler. It's not a filler by itself, it's rather than it's using your own or somebody's own cellular matrix to repopulate the area of something that's missing. And what is missing with aging process is the fat cells get apoptotic, or they do get resorbed with time, and therefore the skin gets thinner, and we start seeing more problems with that. So basically we're talking about Renuva, which is an acellular allograft mattress, and basically it says still you, only better. So basically no product is coming in. It's something from human to human. It's very safe. So there's no PLLA, there's no PDO, there's no hyaluronic acid, and that's why it's a little bit different, especially coming after permanent filler problems. Also could be interesting after using Endolift, where there's depressions and somebody does not want to use fillers.